So as I'm here today to talk a little bit about patient satisfaction. But as a disclosure, as I mentioned, I work for Paladina Health. That is not the solution to DPC for everyone, but I think it is a solution. For some doctors who don't want to take on starting their own practice, it's a nice way to practice in the DPC model and let someone else set it up for you and be responsible for the patients. But I'm not here today to talk about Paladina. I'm not here to advertise for them. I'm really here today as a DPC doctor to talk about satisfaction. And satisfaction in the concept of what is patient satisfaction and what has the evolution been in that concept. I have only one other disclosure, and that is that I am not an expert in patient satisfaction. In fact, many of my colleagues would point out that they have much better satisfaction scores than I do. So, however, in many years in medical leadership, you can't ignore the concept of patient satisfaction, whether that's to help your organization advance or whether that is to help colleagues that may be struggling. So as a medical leader, you have to become well-versed in the concepts of patient satisfaction. And here's a couple of references and resources that I have found incredibly helpful and inspiring. The first two are from a group called the Studer Group. Some of you may be familiar with that. They do a lot of training and consulting on the areas of patient satisfaction and patient excellence and service excellence. And the third one up there is a very interesting book written by Fred Lee, who is a hospital administrator from Florida, who also happened to work for Disney for a while. And so there's some really interesting parallels that he draws. So we'll be referring to some of those. But just briefly, kind of a quick 60-second history of patient satisfaction. The first references typically that you'll see in the literature come back to the 1950s when it was more scholarly interest in how do you measure patient satisfaction and then evolving into how does that correlate with clinical quality. The first commercial patient satisfaction surveys really started to appear in the 1980s, and over the next 20 years those became commonplace. There were a couple of reports that came out in the early 2000s that really drew attention and shed light on the fact that there's really more a sense of patient dissatisfaction with the U.S. healthcare system and some associated fairly significant lapses in quality that seem to be tied to that. So in 2006, the government, as they do, produced their solution to that, which was HCAHPS, which I can never remember, is Hospital Consumers Assessment of Healthcare Providers and Systems. And that was their attempt to somewhat standardize the patient satisfaction surveys and try to be able to give something that consumers, patients, could look at and say, we can compare apples to apples. We can compare one hospital's quality to another. But really, what I want to talk about a little more is the movement that's happened probably just in the last 10 to maybe 15 years, which is looking at patient satisfaction as that pertains to the outpatient environment. We're all used to that in the hospital system, and they've been doing that for years, but it's kind of new for the outpatient environment, and it's really mirrored the rise in consumerism in our culture. So if you look at these, I think everyone will recognize these brands and also recognize that they share some common themes, and one of those is that they use current technology tools. They use web-based platforms, they use smartphone apps, they use even the power of social media to leverage and harness the power of the collective consumer voice. And what they do is they provide that to their consumers, and people go to these sites with the understanding that they should be able to look at past consumers, past customers, and be able to transparently see their reviews and their satisfaction. And so it should be no surprise to us that obviously those same consumers now are demanding the same thing in healthcare. They want to be able to go out there and find out what's happening. And so the reality today is in our medical practices, whether you ever send out a patient satisfaction survey or not, the patient voice has a powerful influence on shaping your practice and shaping the image of your practice in the community. But I think the question all of us should be asking, and particularly the clinicians in the room, is does better patient satisfaction actually equate with better quality of care? Because after all, isn't what we're really supposed to be about providing the best quality of care? And in fact, isn't that what really matters to our patients? Or at least, shouldn't that be what matters to our patients? There's always this tension between patient satisfaction and clinical competence. And I think it's a fair question. Should we really be concerned with patient satisfaction? And so I think my answer is, well, maybe we should ask the patients. And of course, they've done that quite a bit. Press Ganey and Gallup are two of the largest vendors of patient satisfaction surveys in our country. Together, they do hundreds of thousands of patient satisfaction surveys every year. And every year, they publish what they call their top 10 drivers of patient satisfaction. And interestingly, every year, almost every single one of those drivers of patient satisfaction has to do with how the patient is treated as a person, not how they're treated for their medical condition. So the reality is that clinical competence is assumed by our patients. They assume that you graduated from medical school, you passed your board exams, you maintain your state license, you're clinically competent. But they judge us not based by the way they're treated for their medical condition, but by the way they're treated as a person. That's what patients look to as, are they satisfied with their care? So this next case study I want to show, I should put a disclaimer. This is definitely not from a DPC practice. Probably from a large health system, probably certainly fee-for-service. And here the receptionist says, our next available appointment is in 2 months. Will you still be alive? Well, if you sense you're not going to make it, cancel 24 hours ahead, or we'll have to charge your estate. So this is an example of neither clinically competent medicine nor satisfying medicine. And I think the truth is that it's not satisfying to anyone in the system. It's not satisfying the patient. I don't think the receptionist looks particularly satisfied. And certainly as providers, that's not what we want to have. That's not what we want to offer to our patients. But I think probably DPC providers get this. We know that patient satisfaction and loyalty is essentially important to our business. But what is satisfying to us? So I want to just take a minute to look at what is physician satisfaction. What is it that physicians want? I think there's some common things, and we've heard a lot of them already this morning. Physicians want to feel like they're having meaningful relationships with their patients. They want to feel like they're making a difference. Physicians want to feel like they have some work-life balance. And, of course, they want to feel like they're getting reasonably compensated for their work. But one thing that's probably a little bit unique in DPC that some of our non-DPC colleagues don't have to worry about is this concept of physician security. In DPC, and we talked about how to grow your practice, how do you get those patients in, how do they stick with you, how do they continue to sign up every month or continue to maintain their membership. And the reality is that security isn't rooted in patient satisfaction, it's rooted in patient loyalty. And the recommendations don't come from meeting basic needs or expectations, they come from having a wow experience. So it's taking patient satisfaction to a little different level. There's a couple of concepts I just want to share from those books, and one of them I thought was so interesting was called Fool's Gold. And what that means is this comes from the Disney book, and it says, consider patient satisfaction fool's gold. And what that means is if we aim for satisfied patients, we're not only not going to thrive in our practice, but we may not even survive because satisfied patients aren't good enough. In Disney, their sole focus is on the percentage of customers that give them the highest possible score on their surveys. So they don't care about the 6s, 7s, or 8s on the satisfaction survey. They care only about the 9s and 10s because they realize that it's those people who are going to be the raving fans of Disney. Those are the people that are going to be the loyal customers who come back year after year and bring their friends. Fred Lee, who wrote this book, repeats this phrase repeatedly throughout it. He says, a satisfied patient has no story to tell. And the point is that word of mouth, as we've already heard, that's our greatest advocate, that's our greatest promoters, and it's our patients who will do that, but they have to have a story to tell. As the healthcare industry has gotten a hold of this concept of fool's gold, patient satisfaction is fool's gold, they've broadened that understanding. So instead of just talking about patient satisfaction, it's moved into the concept of service excellence, and we saw in the 1990s a lot of hospitals started service excellence programs. But I would say in the last 10 years, we've really started to broaden it out to look at the concept of the patient experience. And it's that whole experience that makes a difference. So let's look at a few principles, particularly again from those books that we can gather about what is it that's going to make that patient experience something significant, that wow factor. So again, if Disney ran your hospital, first concept we've already talked about, don't be satisfied with mere patient satisfaction. Second principle is valuing courtesy more than efficiency. What that means is your staff not only able and willing, but even encouraged to go above and beyond for their patients? Are they encouraged to do things that are courteous and helpful, even if perhaps it keeps them from getting through their to-do list for the day? Another principle, measure to improve, not to impress. We talked a little bit about metrics and the importance of measuring, but really our goal needs to be to constantly evolve and deliver a better product, not just create a better marketing campaign. And so when we measure, make sure our focus is to improve. And finally, they talk about the empower of every employee to say yes. So everyone from the receptionist to the MA, the phlebotomist to the physician should be able to solve a patient problem, a satisfaction concern, maybe a miss in patient care right at the time. Are they able to do service recovery on the spot? That can turn a disgruntled patient, a disgruntled customer into a raving fan if you do a great job of service recovery. From the Studer books, one in particular, Hardwire and Excellence, is really pertinent to this, and they have a few key principles. They talk about building a culture around service, building that culture in your office. And there's a few things that they recommend. One is keywords at key times. Keywords are things that you say and that you build into your routine, not to be trite, but to help your patients understand that you really are there for them, that you care about them and you're there to serve them. Things like, is there anything else I can do for you today? Thank you for coming in. Simple things. They talk about hardwiring service actions. Those are things like using AIDIT principles for your staff to room patients, things that just let people know that you are there for them. Things like callback, phone calls, a day or two after a patient's had a new diagnosis or a new medication change. Those are things you can just hardwire into the routine of your practice, and they make a big difference. But if we want to know really what makes a difference for our patients, there's some research that they present in one of those books that I think was so compelling, and the author calls it a case for compassion. And what this author did is he looked at hundreds and hundreds of patient satisfaction surveys, post-hospital discharge surveys. And what he pulled out of those was 185 unsolicited positive compliments. So these are the patients that went above and beyond. Rather than just answering the survey, they wrote compliments at the end of it because they were so impressed with their care. And what did he find in those 185 unsolicited compliments? 4 of them were about the competence of the staff taking care of them. 61 were about the courtesy, the politeness, or the respect that they received during their care. And 120 were about compassion, kindness, or empathy that they sensed from the staff. So if you're keeping track, that is 30-1 in favor of compassion over competence. Now obviously that's not to say that competence doesn't matter. In fact, that's got to be at the core of what we do. But that's not what touches our patients. Over the years, as people have looked at this patient experience principles, they've come up with this concept of patient-centered care. And what patient-centered care is about finding what's important to the patient, finding what their values are, focusing on patient convenience, and promoting patient empowerment. And those are all fantastic principles. Those are all things that we need to look for and promote in our practices. But when I think about that and I think about the previous research study, it strikes me that there's something missing in that. It's the provider, right? That's us. That's the caregiver. At its heart, primary care is about a relationship between a patient and a provider. And so I've been talking in recent years with my providers about the concept of relationship-centered care rather than patient-centered care. And someone else alluded to it. It's about that relationship. And the patient brings to that relationship, they're the source of truth for their medical history and their current symptoms and their own values, their goals for their health care, and their willingness to engage in that and to maybe make changes. The PCP brings their medical training and their clinical experience, the best current evidence of how to treat their condition, their prescriptive authority, and of course their own values and goals. But when you can bring those two together and create that patient relationship that's at the heart of primary care, you can develop a therapeutic relationship, you can develop a level of trust, you develop that sense of mutual understanding with your patient, and it's a place where patients feel safe, where they feel like they can really be able to share with you what's important to them. And when we do that, we can develop shared decision-making, we can develop common goals with our patients, we can develop a process where we can help them maybe make some lifestyle changes that will make a huge difference in their health. And only through that relationship then do patients start experiencing what they really are looking for, the kindness, the compassion, the empathy. That's what really drives the heart of primary care. So I'll finish with this quote. I think this is so appropriate to direct primary care. This says, there's a profound difference between selling and marketing. Selling is trying to get people to want what you have. Marketing is trying to have what people want. When you have what people want, it makes selling unnecessary. And I really believe that in today's healthcare system in our country, DPC, we have what people want. And so we don't need to sell it. We need to simply live it out, and it'll market itself. So thank you.